Hi everyone and welcome to day 6 of the 10 on 10 series where we are going to discuss 10 questions of microbiology. But before that, the homework discussion of yesterday where I first asked you about Nugent's criteria. So Amsel's criteria for bacterial vaginosis I discussed. Nugent's is a gram stain based and all of you told me correctly a score more than 7 would be significant. Next I asked you the radiology sign which is dural tail sign for meningioma, and then the syndrome which we discussed NF2 and the brain tumors associated with it that I asked you were MIS-ME, that is multiple inherited schwannomas. The first one is schwannoma, the next one is meningioma of course, and the last one is ependymoma. So I got all correct answers in the comments, and what's even more interesting is that apart from the homework, you guys are teaching me so much more by typing out a lot, and thanks for taking out a lot of your time for doing that. Trust me, it's great to read the comments, and I take out specific time slots to read and go through all of them because I get to learn personally a lot from them as well. Moving on now to day 6 where we discuss 10 questions of microbiology, and I told you it's a bacteriology alert, so most of them are from bacteriology. The first one over here is a lengthy question. We'll quickly go through the buzzwords where we have a 35-year-old male patient coming with pain and painful skin lesion and fever. That lesion is on the leg. Physical examination shows erythema that is present, and gram stain is very characteristically showing you gram positive cocci in clusters. Usually they talk about grape-like clusters, and over here the hint of Staph aureus should certainly be coming to your mind. Further, Staph aureus is going to be catalase positive, which is mentioned over here. They are saying that a toxin is released by this organism that is going to affect stratum granulosum. Desmoglein 1 is what it's attacking. So they're asking you the toxin responsible for this. Of course, it is Staph aureus, which produces the exfoliative or the epidermolytic toxins, which are going to act on desmoglein 1, that is the attack side. As mentioned, Staph aureus is also grape-like clusters and catalase positive, all of which it is going very well in favor of it. It is known to cause a couple of skin lesions, like for example staphylococcal scalded skin syndrome is one question that you get in dermatology. Apart from that, the other options that are given over here, let's discuss those as well. There is a toxin produced by Staph aureus called the panten-valentine toxin, which is known to be produced by the methicillin resistant Staph aureus. Then there is an enterotoxin. The word entero tells me that it is going to cause food poisoning. Remember, Staph aureus has an incubation period of less than 6 hours, and that is how you confuse the Staph aureus food poisoning with the Bacillus cereus food poisoning. I'm not writing it hoping that we've discussed it multiple times before and you remember that the Staph aureus food poisoning is because of consumption of food like milk and meat. So milk products are very important, and the Bacillus cereus food poisoning is because of Chinese fried rice. Both of them have an incubation period of less than 6 hours. So enterotoxin causes food poisoning except enterotoxin F, which is also known as the toxic shock syndrome toxin because it causes toxic shock syndrome. Another thing that we've discussed earlier is that the history of retained tampons and menstruation would be mentioned when discussing toxic shock syndrome. The last one is alpha hemolysin. So there is alpha, beta, gamma, delta. All four hemolysins are known to exist for Staph aureus, but what's important is that sometimes the PV toxin and the gamma hemolysin, repeating, we had learned it and written it like this, that PV toxin and which hemolysin, the gamma hemolysin, together are known to act and are known as the synergohymenotropic toxin. All of these are core bacteriology questions, but over here, since skin was involved, it is the epidermolytic or exfoliative toxin. That's question 1. Question 2 is a 45-year-old male patient coming with fever, chills, and productive cough. Physical examination shows consolidation in the right lower lobe. I could be thinking of pneumonia considering this history and radiology. Along with that, let's go on to sputum culture over here, which shows an organism to have partial hemolysis on blood agar. Now, all of you have learned hemolysis as alpha, beta, gamma, but now you should know that what color is produced? Greenish color. Greenish color always tells us about alpha hemolysis. And now in alpha hemolytic category, we have two organisms. One is known as Streptococcus pneumoniae and one is known as Streptococcus viridans. So the other two are automatically ruled out. Enterococcus belongs to the gamma hemolytic category, and group A Streptococcus is known as group A beta hemolytic Streptococcus. So that of course belongs to beta. So now I have two options. Either it's pneumonia, which going by the clinical history physical examination is also this, but also further when I read the optochin sensitivity and bile solubility further tells me about pneumonia. So let's study this in detail. Based on hemolysis, we have alpha hemolysis, beta and gamma hemolysis. I've written it in the same color because alpha hemolysis, which is the partial hemolysis, gives a greenish color. Beta hemolysis gives a yellow color, and gamma hemolysis does not have any hemolysis, so there is no change in the blood color. It remains the similar blood agar. Under alpha hemolysis, we have two organisms learnt as VP, that is Streptococcus viridans and Streptococcus pneumoniae. Streptococcus pneumoniae is said to be biopositive and viridans is bionegative. What is bio? Bio stands for three tests which are done. Bile solubility as mentioned in this question. So pneumonia will show everything. B for bile solubility, I for inulin fermentation, and O for optogen sensitivity. If these are mentioned and the clinical history of pneumonia is there, you're going for this answer. If it would have been bio-negative, I would have thought of viridins, and the clinical history would have probably been related to the prosthetic heart valve endocarditis. That would have been bio-negative. Moving on to question, before I move on, in fact, since you've mentioned Streptococcus pneumoniae, I hope you remember the organism is going to be a lanceolate or a lens-shaped organism, and it has a capsule around it just as mentioned in the question, and the characteristic colonies which I taught you in the image session are also known as the Karam-Cohen or Drotzman colony. Moving on to question 3 over here, which of the following is not a virulent factor for Neisseria gonorrhoeae? So over here, when we talk about Neisseria meningitidis or Neisseria gonorrhoeae, all of these like OMPs or outer membrane protein are for virulence factors for both. IgA protease are also going to be for both. The pili, especially the type 4 pili, are for both. What is not a virulence factor is the M protein, because if we remember correctly, M protein is the one that is implicated in the pathogenesis of rheumatic heart disease. That is caused by group A beta hemolytic streptococcus, GABS. And what is it? Streptococcus pyogenes. So that is not to do with Neisseria, and the answer is M protein over here. So the question was not knowing about Neisseria. The question over here was whether you were able to pick out the odd one out, which is M protein, which I definitely know is for Streptococcus pyogenes. So sometimes it's not the direct way of solving a question, but also by searching the option that you probably know for another bacteria. Now let's start with the questions that can be asked over here. When we talk about their shapes, Neisseria meningitidis, the way you write an M, we had made a lens out of it. So it is a lens-shaped organism, and it is also going to have a capsule. Neisseria gonorrhoeae, we write the G and G, so that's going to be a kidney-shaped. Over here you can see multiple neutrophils because they have many lobes. Inside the neutrophils, I can see some ... organisms, intracellular organisms. When I zoom into those organisms, the classical kidney shape is evident to me. So that is done for gonorrhea. That is exactly what they had asked you also. When they're talking about Neisseria meningitidis or gonorrhea, the transport media for both is going to be the Amy's media or the Stewart's media. Another way of learning it we had done for Neisseria, nice, it is going to be Amy's. So transport media is Amy's media, whereas the culture media for growth is the modified Thayer-Martin medium. So question 3 is also done. Moving on to question 4, which is a question of bacteriology and I would say even immunology combined. And before the question starts in the comments that ma'am please take a session on immunology, I would definitely take one, but let these 4 days of 10 on 10 be over and then we'll take an immunology session. Moving on to next one. There's a 21-year-old man presenting with fever and headache that has lasted for 2 days accompanied by nausea, vomiting. The doctor suggests a blood culture, upon which the condition they've been nice enough to tell you it is a meningitis caused by Neisseria meningitidis. 4 months ago also the patient had a similar Neisseria infection. So now such back-to-back Neisseria meningitis infections, they are asking which complement deficiency can be associated with it, and the answer is C8. Basically the previous year question was asked and I've written everything related to this question asked in PYQs, that whenever there is a terminal complement deficiency, the complement pathway ends as what? The last product formed in the complement pathway is the membrane attack complex. What is it made up of? It is made up of C5b to C9. That's the C5b to C9, the composition of membrane attack complex. If someone has a deficiency of membrane attack complex, that means it's the last part of the complement pathway. So I'm saying it's a terminal complement deficiency, or I can say it's a deficiency of C5b to C9. All three mean the same. Terminal deficiency or MAC deficiency or C5b to C9 deficiency, whatever may be written, like C8 is definitely coming in this zone. These patients are at a risk of Neisseria meningitidis infection as mentioned in the question. So the answer is C8. But what if there is a problem in the early complement proteins? How does the pathway start? It is C1, C2, C4. These are the early pathways, right? The early complement proteins deficiency or defects are associated with autoimmune disorders like SLE. That has been a NEET PG PYQ, which I don't think students give much importance to. So in case you missed out on this, you should know. Then a recent question was if there is a C1 esterase inhibitor deficiency, that results in HAE, hereditary angioedema. Patient has multiple edema episodes which are seen seen around the eyes, they can be seen around the lips, and most dreadful is when it is seen around the larynx, because then there is going to be respiratory problems, difficulty happening. So emergency room is what the patient would be presenting to. Coming to the next one, which is from Himat, decay accelerating factor, which we know as DAF. DAF is the other name of CD55. And then it has a cousin brother called MERL, which is the other name of CD59. So CD55 and CD59 deficiencies, which anemia? Paroxysmal nocturnal hemoglobinuria. So everything related to complement proteins. And how is CD marker? I mean, the complement proteins, I can understand C1, C4, C8, they are to do with complement pathway. How is CD55 and CD59 related to complement pathway? Because normally in all of us, 55 and 59 are controllers of the complement pathway. They control unnecessary activation of the complement pathway. So they are very much a part of the complement system. Question 4 also done. Moving on to question 5, where you'll also find your homework for the day, is a young boy who comes to the physician complaining of rash and irritation after a flea bite. As soon as the vector comes, you have to narrow down to a few diseases. Either they have gone into, if it's a rat flea, maybe they're talking about plague. If it is to do with flea, maybe they're talking about the Rickettsia family. So let's see further. Now when I see this is in a wheat grain go down, and after 5 days there is fever and axillary lymphadenopathy. A smear was sent to perform a specific staining. Which of the following staining methods would help? So now over here, considering the wheat grain where rat infestation is very common, and they have mentioned flea, and after the bite of that flea there is axillary lymph node and fever, probably this is a case of bubonic plague that has occurred. Bubonic because of buboes, and of course fever would be there. Now when I also look at the options over here, number 1, let's go option by option. If I look at Albert staining, that is for the volutin granules of Corynebacterium diphtheria. Diphtheria presents with a bull's neck and pseudomembrane, so automatically it is ruled out. Zn stain can be done for a whole lot of things, but TB comes first to mind, and that has nothing to do with flea bites, so ruled out. McFadden reaction, M for M, is to do with polychrome methylene blue staining. It is done for the seeing the capsule of Bacillus anthracis. Is this an anthrax history given over here? Because that is to do with people who carry animal skin on their back, and then from the animal skin they get an eschar that is there on the neck. Nothing of that sort's mentioned. So again, it is ruled out. The correct answer is the Vasen staining. I've got you the kind of questions which you miss in your rapid revision videos. I'm not asking you questions like toxic shock syndrome, retained tampons, which you already know. I know you know the food poisoning of Bacillus cereus and Chinese fried rice. Those are on your fingertips. I know where you're going to forget the things that what I've added. You will forget that in plague, you will remember Yersinia pestis. But what you will forget is that how does Yersinia pestis look under the microscope? It shows a classical safety pin appearance. How does a safety pin look like? What baby questions are you asking us, ma'am? This is how a safety pin looks like, because if they don't write safety pin appearance, they will write bipolar staining. Please don't mess up. Don't think you have not read it. You have. Bipolar staining at the two ends. That's what makes it a safety pin. And what is the stain that we've used over here? It is the Vasen stain, which I know you might have forgotten during your rapid revision study. So that is the answer over here. Even if you were ruling out, you could have come to an answer. Okay, moving on to what is your homework for the day is that you're going to give me a list of multiple other safety pin appearances that you see in microbiology. Again, a list that you forget, and hence I'm going to make you only write it today in the comments. That's your only homework for the day. Moving on to question 6. The 26-year-old male over here presents with fever. Everyone today has fever, with abdominal pain and diarrhea. As soon as diarrhea starts, there is a certain set of Salmonella, Shigellas, and Vibrios in these bacteria that start coming to my mind. So let me see further. There's a history of consumption of raw fish 3 days back. Now, when they start talking about seafood, out of all of these mentioned over here, definitely Vibrio parahemolyticus is one differential diagnosis that I've kept. We had learned that Vibrio parahemolyticus, P for prawns and some kind of fish, so seafood would be mentioned. Then further investigation tells us that culture grew in Vagatsiuma agar. Vagatsiuma agar is nothing but a typical blood agar. What you've added extra to it is basically salt. So you want an organism to grow, this organism loves salt. So is Vibrio parahemolyticus a halophilic organism? Yes, this is a halophilic organism. It is salt loving, halophilic, salt loving living organism. Vibrio cholera, on the other hand, is going to be non-halophilic. Anyway, Vibrio cholera would have had rice water stools, which is a totally different history that would come. Shigella would come to us more with dysentery, and Salmonella and typhoid is something which again has those rose spots and totally different, maybe fever with bradycardia, such kind of histories given, nothing of that sorts. Here you have a positive history of fish and prawns. You think of Vibrio parahemolyticus, you are going to grow it on the Vagatsuma agar, and on Vagatsuma agar it tends to show you a very famous phenomena known as the Kanagawa phenomenon, which was also the recent INICT question. All of this for Vibrio parahemolyticus, very, very important. Moving on to question 7, because we just spoke about cholera, I want to ask you that what does fragment A of cholera toxin do and how does it produce rice water stools? When I say fragment A, this means cholera toxin has fragment A also and it has fragment B also. We've always studied that A is going to be for action and B is going to be for binding. So how does cholera come and bind? It binds to the GM1 ganglioside. That is very, very important. And after that, what is the action? Action is elevation of cyclic AMP, that is does. And now let me see, where can I see over here cyclic AMP is not there. So I look for options. Which activity am I talking about? It is the adenylate cyclase activity, and I'm saying that has to be increased. Please don't read this adenylate cyclase in the exam and say ye answer hai, because it's not inhibiting, it's activating adenylate cyclase. So option C is the answer over here. I know we've revised this multiple times, but why not one last time? All the toxins that increase cyclic AMP and cyclic GMP. For cyclic AMP, we have the mnemonic cyclic AMP. In fact, in the last 10 on 10 series, you guys had only written it in the comments. So I'm just giving it back to you as from your own comments, putting it out there. C for what? Cholera toxin, like over here Vibrio cholera. A for anthrax, a very important category, a bioterrorism agent. The M we had changed into E, so that is E. coli. Which toxin of E. coli? There are two toxins, one is labile toxin, one is stable toxin. We always study a labile person will talk in the air and a stable person will always be grounded. So labile toxin in the air means it will increase cyclic AMP, and stable toxin on the ground means it will increase cyclic GMP. Coming to the last one, P for pertussis, whooping cough. So these are the four that increase cyclic AMP. We've also done what increases cyclic GMP, but now comes that Chinese fried rice and Bacillus cereus story, because Bacillus cereus causes food poisonings, which is of two types. Either the patient is coming to you with emesis or vomiting, or the patient is coming to you with diarrhea. Now, vomiting always happens from the gala. So, gala means cyclic GMP will be increased. Diarrhea always happens through the anal canals. So, cyclic AMP will be increased. That is how we had learnt it. All the toxins are done. Moving on to what Vibrio can show you. Again, a quick screenshot which I've got from the recent images that I taught you. How does Vibrio look like? It is a comma-shaped organism, and I'm putting a star here because it moves very fast, like a shooting star motility. If you want to grow it, which is the culture media, TCBS media, I taught you which fermentation, sucrose fermentation, what color does it give you, Vibrio cholera, yellow color. So here you see a yellow color, sucrose has been fermented. Here you don't see a yellow color, sucrose has not been fermented. And without asking you, I know this is obvious that it shows a positive string sign. So these are all the features. One last time for Vibrio. Because you're talking about something on similar, let me ask you question 8 over here and let's see if you're able to answer it, because string test, string sign. Let's see if you've read it somewhere else. Now here what you have in this patient is a 28-year-old woman or 28-year-old patient who comes to the clinic with persistent watery diarrhea, abdominal cramps and dehydration. First part of this entire series had fever, and now the second part has all diarrhea. Stool examination does not show any significant finding. To identify, a string test is performed. As soon as this is string test, there is obviously one organism coming to my mind, that is Giardia lamblia. Giardia lamblia has a property that it will always be found in the duodenum, roaming in the duodenum. So now if it's not coming in the stool, trophozoites are not seen, you will have to go and get the trophozoites from the duodenum. For that, you will have to send a string. So the correct answer, if we see, is the string test done to collect bile samples from the duodenum? Not at all. Is the string test done for H. pylori? Again wrong. The string test helps identify by extracting samples from rectum? No. The string test helps in identifying small intestinal infection by retrieving the duodenal contents. Yes, because duodenum is where the Giardia lamblia is going to be present, and we know it shows that classical falling leaf motility also, right? Girta hua leaf, Giardia lamblia. So that is the string test. Right now I showed you string sign for Vibrio cholera. Now I'm showing showing you the string test for Giardia lamblia. These are very important questions for the exam. You just spoke about Giardia lamblia. So your next question is on the same lines. I've tried to create a continuity in the questions so that it becomes a little interesting for you, because otherwise micro is not. So which immunoglobulin deficiency is associated with Giardia lamblia infection in a 23-year-old male with stomach pain, excessive gas and fatty stools? Firstly, Giardia lamblia does cause malabsorption, and that is the reason fatty stools are there. So in other words, the examiner is telling you about steatorrhea. Now, when they're talking about GI infection, GI means mucosa. Mucosal antibody is always IgA antibody. Recently in the image section only, I told you that IgA antibody is the one that is capable, not always, but can exist in a dimeric form, means two antibodies will be together and they will be connected by a joining chain or a J chain. So this is a dimeric form. Now there are actually two properties of IgA that you have to know. Why is it called as the first line of defense? Because number one, it's present in all our mucosas. It's present in the respiratory mucosa, it's present in the GI mucosa. So imagine if there is immunoglobulin A deficiency, then of course Giardia lamblia infection will be more, because the GIT is not being protected, and that's the answer over here. But other than mucosal antibody, it is also known as secretory antibody, because it is present in the body secretions also. For example, it's very breast milk is very rich in IgA. So yeah, question 9 is also done. Moving on to question 10, because it would be a crime if I don't include something on this in every session. That's how important it is. There's a 25-year-old woman. I don't think you're reading any of this over here, because they mentioned HPV cells positivity in the tumor cells. So there is a cervical cancer because of gynae examination, cervical biopsy. There is HPV positivity. They've asked you. You've done that P53 and all of those questions. But the here question is a little twisted, which says, what is the role of HPV in the pathogenesis of neoplasia? How does it cause cancers? Well, all of you have studied that HPV has two very important proteins. If I can show you those proteins, those are E6 and E7 proteins, and they are responsible for causing cancers. But how? E6 will inactivate our policeman, which is P53. E7 will inactivate governor of the genome, RB gene. Do you remember? P53 is known as the policeman of the genome, and RB gene is known as governor of the genome. And both of them are going to be inactivated by E6 and E7 respectively. But what exactly is P53 and RB gene? Because I don't see them written over here. Are they oncogenes? Are they telomerase? Are they some insertional mutation happening? Or are they tumor suppressor genes and proteins? Yes, so P53 and RB gene, normally in you and I, they are tumor suppressor genes and proteins, and I'm inactivating them. So this is actually an inactivation of the tumor suppressor genes that is occurring. And now what is this cell that they have shown over here, which I've taught you again in the image based session, which is a koilocyte? I'm really trying to link things in this 10 on 10 series. So if you maintain the continuity, which is demanding only 10 to 15 minutes of your day at the max, only for these MCQ sessions. Otherwise, the image ones were even shorter. 10 minutes on 2x is 5 minutes. So this is going to actually help you if you watch them in continuity. So koilocyte, as you remember, is a rhazonoid nucleus with a perinuclear halo, which is associated with HPV. And which proteins of HPV were responsible for the koilocyte? It was the E4 and E5. And this is what you had told me in the homework a few days back, that a similar kind of rhazonoid nucleus with perinuclear halo, if it is an RCC, it will be a chromophobe RCC, if you remember. So now that you've told me everything, where do you use the L1 capsid protein that is used for vaccine preparation? It's a hat trick question. It has come in FMG, NEET, INI of the same year. That's how important it is. Then, of course, a much not expected question, because it was so simple, was asked recently in the INI exam regarding the low risk and the high risk HPVs. And I think you know it, the 6 and 11 are the low risk ones, and 16 and 18 are the high risk ones. And believe it or not, this was the question, that which high risk HPV causes squamous cell carcinoma most commonly. It is a high risk HPV 16 and 18. Well, that wraps up the 10 questions for the day. Your only tiny little homework is that you have to tell me all the safety pin appearances. Reason being, I want you to type it, write it, and learn it before the exam. Now, the next 2 days that we'll have will be match the following. So leave that to me, whether I want to make you match images or I want you to match some tough genes, chromosomes, some culture media. So we'll alternate path and micro for match the following. This is not, of course, this is a kind of a pattern that you get in the exam, but this is also going to be a very fun way of learning, and it will break the monotony a little away from images and MCQs, and it will help you, recall a lot better. So yeah, see you for the next 2 days, waiting for the homework answers.